Great. Hi, everyone, as you're just trickling in here. I'm Erica Schiavelli. I am the Deputy Executive Director here at the GIC. We're just giving folks a moment to get logged in before we get started. So please bear with us just for a couple of minutes. As we see our participant numbers continue to climb, we just want to give everyone a chance to get in. All right, looks like we're kind of slowing down a little bit on the list of, or the number of participants joining us. So I'll go ahead and get us started. Leslie, if you could advance the slide, please. Great, thanks, Leslie. So as I mentioned, my name is Erica Schiavelli. I'm the Deputy Executive Director here at the GIC, and I wanted to thank you for joining us for the second of our 3 public information sessions that we're holding this week. These sessions are part of our annual process to develop and finalize the design and premium rates for health insurance plans for the coming annual enrollment. So we hold these sessions virtually by Zoom and also live streaming on YouTube. And we'll post the video of this session as well as the slides on the GIC's website. We will also be updating our FAQs, which are also on our website, after these sessions to make sure that our FAQs reflect the questions that you have all asked here today. So our plan is to do our presentation followed by the Q&A session. I'll be joined by Matt Bino, our executive director, as well as members of senior staff who will be presenting and helping throughout the question and answer portion. Sorry, I'm having a little bit of a cold, so just bear with me here. I wanted to note just a few housekeeping items. As always, your participation in the public information session is not required for you to participate in annual enrollment. It's completely voluntary and informational only. Closed captioning is embedded in the live stream as well as in a link provided in the Zoom chat. And we also have ASL interpreters available. If you're having trouble seeing our ASL interpreters, please let us know, and we'll try to troubleshoot that in the background. So moving to our agenda slide, we're going to go through a quick overview of the GIC, who we are, how we're structured. Then we'll move on to our benefit partners for the current year and for the upcoming plan year. We'll review potential changes to your health insurance premiums and plan design. These are potential changes that will be up for the commission to vote on February 12th, but we wanted to review all of those potential changes with you all here today. Then we'll move on to enrolling in and updating your GIC benefits. And from there, we'll move on to questions and answers. Next slide, please. Great. So this slide shows a little bit about what you need to know for submitting your questions to us. So we're using the question and answer function via Zoom to take and answer all of your questions. So please only use the Q&A function to ask your questions. If you are live streaming via YouTube, you won't be able to use or see the Q&A function, although I don't believe that will be an issue for us in this session today since we are under the 1,000 participant threshold. But just know if you do choose to move over and watch it via live stream, the Q&A function will not be available. So your questions in the Q&A function are private until they're answered, at which time they will become visible to all attendees. Again, this is not something that you'll have access to if you're viewing from YouTube, but I don't think that's a problem for this session. We'll only be taking questions in the question and answer format. I understand that there's a lot of feedback that folks have that they want to deliver to us and to commissioners, and we are happy to receive that feedback. But please don't use the Q&A function for that. If you have feedback, commentary, etc., that you'd like to share with us, you can use our gic.info@mass.gov. I am actually personally monitoring that inbox. and we'll be able to compile and share your feedback as members with our commissioners, with staff, and others. So please know that when you do email gic.info@mass.gov with any further feedback, commentary, etc., you'll get an automatic reply, as is the custom for that inbox. But please know that I'm here, actual human person in the background, looking at this inbox and sorting it so that we can provide that information, your feedback, to commissioners. And while we're talking about questions, like I said, we do have a frequently asked questions page that you can see here on our website. And we'll also post it in the chat as well for folks to access. So please take a look at those FAQs maybe before you ask your question, and see if your question is answered in the FAQs. And if not, go ahead and ask your question and we'll address it. If you could move to the next slide, please.
Sorry to interrupt. The audience is saying they cannot see the interpreter even though we're spotlit.
Thank you. Let's see. Let me just try this. Hold on just one moment. We were having a similar issue in our last call. This seems to have done it. So, okay.
Thank you.
Great, no problem. Great. Okay, so if we could go to the next slide, please. After GIC overview, we're just going to talk just a few important facts about the GIC. We really like to start with a reminder about our mission. And we just want to highlight a couple of things within our mission. So first, you'll see the word members. You're always at the heart of what we do. As Matt, our executive director, likes to say, we serve those who serve, whether it's the Commonwealth and one of the other regional local public employers who are part of the GIC, or you all here today, retirees, et cetera. So the second thing we like to highlight is high quality and affordable benefits. This is something that's going to come up quite a bit today. The key here is for GIC is balancing two important objectives. So we're focused on providing comprehensive, high quality benefits, but we also need to do that at a cost that's affordable and that the Commonwealth's budget can afford. This second challenge of affordability is getting harder and harder, and we will certainly touch more on that later throughout this presentation. Next slide, please. Great. So we have our first two goals that come directly from our mission, providing access to high quality and affordable benefit options and limiting the financial liability to the state and others. Our third goal is interesting because the GIC has so many members. We also have the opportunity to influence the healthcare market for the whole state, and we take that responsibility very seriously. Finally, we're focused on being as efficient and effective as we can so that we can serve you all well. Next slide, please. Great. So this is just a quick overview of what our benefit offerings are: health, dental, vision, life insurance, long-term disability, healthcare independent care, flexible spending accounts, and an employee assistance program. Next slide. And here just a few quick facts, GIC by the numbers. So right now we're at about 460,000 members. We're governed by a 17-member independent commission. And we have, excuse me, we have over 100,000 retirees, which makes us the largest purchaser of healthcare insurance in the Commonwealth, the 467,000 members of which 100,000 are retirees. And that makes us the largest purchaser of healthcare in the Commonwealth with a $2.8 billion appropriation from the state. Next slide, please. Thank you. So this slide, I want to take a second to pause on, as it really explains how the GIC is financed. And it may look a little bit different from what folks are used to. So just want to take a moment to explain this. So the GIC is self-insured, which means that the GIC through the state budget holds the insurance risk and not the carrier that you're enrolled with. So when you receive healthcare services, your doctor sends a bill to the insurance company, and the insurance company pays the doctor. The insurance companies then bill the GIC on a weekly basis, and we reimburse the insurance company for those claims. So an important feature of this is that if over the course of the year, members use more healthcare services than we projected, it's the state who will pay the difference, but you, the member, just do not. And if members use fewer healthcare services than we projected, you, the member, sorry, the insurance companies aren't kind of getting the profit from that. It's the Commonwealth that ends up with that reversion to the general fund. So, wanting to use an actual real life example from last year to highlight that here at the end, close to the end of the fiscal year, the GIC requested and was given a 240 million supplemental appropriation last year. And that is to cover our claims that ran over what was projected at the outset of the year. So this is a perfect example of the claims having gone over, the Commonwealth holds the risk, and the Commonwealth paid for the claims at the end. In years where folks do not, where we don't need a supplemental budget, where we've made our budget or we've come in under budget, that amount reverts to the Commonwealth. So just want to take a moment to highlight here that this is how the GIC was designed to function in our establishing statute. That when we come to the legislature and ask for a supplemental appropriation at the end of the year, this is why. It's because the Commonwealth holds the risk and must pay the claims. So if we can move to the next slide, please. Great. And this is again just a highlight about asking and submitting questions. We will do our best to answer them in writing behind the scenes for you. Our last session, I'll let you know that we were bombarded with lots of questions and we did our best to get to them all. But please know that these sessions will be posted online on our website and on the GIC's YouTube page. We will be updating the FAQs after each of these sessions to make sure that all of your questions are reflected. So if your question doesn't get answered today, don't worry, we will be looking at it and we will get to questions. So I would like to turn it over now, I believe, to Cameron McBean, who will take us from here.
All right. Thank you, Erica. We can move on to the next slide, please. Erica's touched on the benefit plans that we offer, so we wanted to take this opportunity to remind you as to which insurance carriers actually provide these benefit plans. So our non-Medicare health plans are available to active employees as well as non-Medicare retirees, and eligibility is determined based on your state of residence as a GIC subscriber. If you live outside of New England, but still within the United States, you're able to enroll in Access America. We have a number of broad network plans that are have wide networks access to most providers in any given state or region. Those include the WellPoint Total Choice, which is available throughout all of New England, as well as WellPoint Plus. Total Choice, if you happen to be an international resident, is also the only option available. Harvard Pilgrim offers the Explorer point of service or point of sale plan. That does require you to elect a primary care provider. And then there is the Mass General Brigham Complete HMO, which also requires a PCP. Then we've got a number of limited network plans. We have the Quality HMO, which is available from Harvard Pilgrim, and WellPoint Community Choice, as well as the Health New England HMO. Now, these are not available throughout the entire state. Health New England is essentially limited to central and western Massachusetts only, and the Quality HMO and Community Choice products are not available on the Cape or Islands. Next slide, please. If you are eligible and participating in Medicare, you have three what are known as Medicare supplement plans to choose from. One each is offered by WellPoint, Harvard Pilgrim, and Health New England. And then we have one Medicare Advantage plan available that's the Tufts Medicare Preferred. Next slide. Then for our other benefit plans, when it comes to prescription benefits, which we will be delving into in greater depth beginning here in just a moment. If you are on an active or non-Medicare plan, your prescription benefits are administered by CVS Caremark. If you are a Medicare participant, then your benefits come through CVS SilverScript. For those GIC members in a GIC sponsored dental and vision plan, that is offered through Altus Dental for active state employees that would primarily consist of management or non-union personnel. Altus is also the retiree dental and vision provider. And we do have some links available in the Q&A regarding Altus because we had some questions about them in the earlier session this morning. We cannot make a final announcement on the flexible spending account administrator yet because that procurement is still not officially complete. We will have a vote for the new administrator for the FSA plans in our upcoming commission meeting on February 12th. And with that, I think we're going to advance the slide, and I'm going to hand things over to our director, Matt Vino, to speak at greater length about GLP-1s and what we've done to try to maintain access.
Thank you, Cameron, and thank you all for joining us. Happy to be here with you. So yeah, we're going to transition a little bit to some mid-year changes regarding the class of drugs called GLP-1s, which are used for the treatment of obesity. I know many of you have questions about this, specifically why we decided to implement this program. As many of you may know, there was a veto in this year's budget of about $27.5 million. That's of the GIC's budget. And we were asked by the governor at the time to consider eliminating coverage for GLP-1s to treat obesity mid-year on January 1st of this past January 1st. This would not have impacted at all other conditions such as diabetes. There was a separate bill that was filed in the legislature that would have allowed the commission to make a mid-year change, but that did not pass the legislature. So as a result, the GIC had a budget deficiency of that amount, and we needed to find another way to manage within our budget, and particularly to manage our spend for this class of drugs. So I'll review here how we chose VITA in the next couple of slides and some other details, but first want to address some of the frustration and concern that many of you have shared with us regarding this transition. So these drugs are enormously expensive, as I'm sure you know, and they have therefore had a very outsized impact on the GIC's budget and therefore the Commonwealth's budget. We were faced with either eliminating coverage for these drugs for the treatment of obesity or implementing a program like VITA that would allow us to maintain coverage while managing the cost. We understand that this change is a concern and may not be welcome by many of you, particularly in light of the change to our formulary that CVS made last summer that may have required you to switch drugs. But when faced with choosing to maintain coverage or eliminate it, the GIC opted to implement this program so that we could maintain coverage for our members who most need it. So now I've addressed the why, let's get into the how of how we ended up choosing VITA Health. So on the next slide, you'll see some of our evaluation goals and how we vetted our vendors. We needed a solution that we could implement quickly, mid-year, and that could produce meaningful savings near term for the GIC so that we could address that budget deficiency. We also wanted to make sure that it was a high quality program that had experience working with clients our size and could provide the level of service, the high level of service that we require for our members. So on the right here, I won't run through all of this, but you can see that we did all of the due diligence that we would typically do in selecting a vendor, just to make sure that they meet our requirements. On the next slide, you'll see how we ended up selecting Vita Health. If we can move to the next slide, perfect. So we selected Vita based on the strength and comprehensiveness of the program, the tools and resources that they provide to our members, and the fact that it is an evidence-based program that's able to support a culturally diverse population such as the GICs. The impacts you'll see here for members, if you are seeking a GLP-1 drug for weight loss, Vita Health, the clinicians and medical experts there in weight management and diabetes management, they are the sole prescriber for GLP-1s for weight loss. We estimate that this will save us about $30 million annually towards, again, speaking to our need to manage the cost. Members will maintain access to GLP-1s if and when it's clinically appropriate, and if they continue to stay engaged with the folks at Vita Health as they're required to. And really because it gives you access to a multidisciplinary team of clinicians with a variety of expertise, with wide expertise in this area. So with the why and the how taken care of, I want to leave it on this slide, and I'll speak to some of the questions that we've been getting from members since implementing the program. So who is Vita for? Well, it's a platform that's available as a benefit to all GIC employees, whether you are using a GLP-1, seeking a GLP-1 drug, or just want to be able to better manage your care. If you are currently prescribed a GLP-1 for treatment of obesity, you'd like to continue on that prescription, you must enroll with Vita, again, as they are the sole prescriber for the GLP-1s for obesity. If you have diabetes and you're prescribed GLP-1 for diabetes, you're not required to enroll in Vita, and your prescription will be maintained through your existing provider. Again, this is limited to GLP-1s for the treatment of obesity. So when do I need to enroll in Vita is a question we get. Well, Vita was launched for our population on January 1st of 2026. We are currently in a 90-day grace period that allows GIC members who are currently prescribed and using a GLP-1 for obesity to enroll in Vita and have their prescriptions transferred accordingly. If by March 31st you have not enrolled in a program or finished your requirements, your existing prescription will likely be denied at the pharmacy. For this reason, we strongly encourage you to get enrolled now to avoid any potential disruptions that may come to you. Another question we get is, how will Vita produce savings to the GIC and therefore the Commonwealth's budget? Well, some programs that are like Vita are de-prescribing models, so they actually have a time frame within which you need to come off the drug. Vita Health is not that type of a model, that type of a program, but we do achieve savings when a significant number of our members who are on GLP-1s come off of those drugs. This attrition of coverage can occur for various reasons, some of which I've already mentioned. If you choose not to enroll with Vita, if you don't complete your enrollment, and if you're if you fail to continue to stay engaged with the providers at Vita Health. What we really hope to see is that those who most need these drugs and are most willing to engage with all the requirements of the program can continue on these drugs. Another question that we get about GLP-1s regarding data privacy and Vita, and for that, I'll turn briefly to our General Counsel, Andrew Stern. Andrew?
Good evening. Vita is HIPAA compliant. The website is HITRUST certified, which is a HIPAA certification. All of your personal data, health-related data that flows through Vita, just like any other telehealth provider, is protected by HIPAA. It is not being monetized. It's not being sold. It can't be. In addition, we have a business associate agreement with them because we are a covered entity, which is also reinforces the HIPAA protection. And I think that should answer the question.
Great. Thank you, Andrew. So we'll be touching more on GLP-1s a little bit later on in the presentation, but I want to move on to the next section, which is what I suspect a lot of you are here for, which is to walk through the potential plan design changes that will be before our commission for a vote on the 12th of February. So on the next slide, I just start with a little context for the changes that we are proposing for the coming year. Healthcare costs continue to rise sharply for everyone, and that includes the GIC. Based on our analysis, if we were to make no changes to the GIC benefits, we would be projecting a 10.9% average increase in our premiums for the coming year. So on this slide, you see that in the purple box in the middle. This translates into about $170 million increase to the GIC's line item in the state budget. And given the state's challenging fiscal picture as we head into the new fiscal year, the governor's budget office informed us in the fall that the state budget really cannot accommodate this increase in state funding. So they requested that the GIC develop and consider a series of benefit changes to reduce our budget line item by about $100 million. Those are the benefit changes through plan design that we present to you today. And again, those will be before our commission for a vote on the 12th of February. On the next slide, we talk a little bit about what's driving health insurance premiums up. We understand this is a hardship for all of us, and we take this challenge very seriously. But the challenges to healthcare affordability are very real, and I'm sorry to say they are increasing, again, for the GIC and for everyone else, no matter where you get your insurance. When healthcare costs go up, the cost of premiums to pay for them also goes up. And this is driven largely by two main dynamics. Number one, the prices that are charged by doctors and hospitals for the services that they provide. Those are rising at an even faster rate this year than last year. And again, this is a problem that the whole state and state leaders have to face. Also, the cost of prescription drugs continues to increase this year more than last, as the manufacturers of those drugs command higher and higher prices, particularly for new drugs that they bring to market. Case in point being the GLP-1 drugs for obesity that we've already mentioned. In the yellow box at the bottom here, just flag that to tackle these core drivers of rising costs, Governor Healy launched a healthcare affordability working group just the week before last, and charged this group with developing real solutions to these longstanding challenges and problems. As the executive director of the Group Insurance Commission, I look forward to participating in this work, representing you, And you can be sure that I'll be advocating hard for solutions that can preserve the value of your insurance benefits. On the next slide, just one more bit of context setting. As you all know very well, we all pay for healthcare services in two different ways: through health insurance premiums that both you and your employer share, and out-of-pocket expenses that you pay directly. These co-payments and deductibles, often referred to as cost sharing. The richness of the insurance plan generally is described by how much of the total cost is covered by the insurance premium. And since the GIC has worked very hard to keep member cost sharing low and stable, our benefit levels are comparatively quite high. So you'll see here in these charts that almost 92% of the cost of services that are sought by our members are paid for by premium and not cost sharing. So premium, which is shared by your employer. And I think it's important to note here that even with the plan design changes that we'll go through in the next few slides,
Matt, I think we maybe lost your audio. It looks like we lost Matt's audio. Oh, hold on just a moment. Hi, folks. Just bear with us for 1 second while we try to get Matt back on here. All right, Matt is logging back in. He got kicked off. Please just bear with us. I'm so sorry. I think what we'll do while we're waiting for Matt is I can provide a little bit of background just for folks to know about kind of what we're going to be doing with this information here today. So we'll be posting the slides and the recordings for each of our public information sessions. Those will be available probably early next week once we're able to kind of package all the materials up. We'll also be going through all of the questions that you've already been asking today, and as well as the ones that we're not able to get to today. We'll be revising our FAQ document based on that. So please stay tuned for that. Just a reminder that the commission will be voting on the potential plan design changes that Matt is about to go through on February 12th. These are not things that staff has brought to the commission necessarily as recommendations, but these are the levers that the commission has available to them to meet the budget target that Matt has referred to. So just wanted to share that with you all while we're waiting for Matt to get back on. Annual enrollment will be April 1st to May 1st. for folks who have been asking. Just trying to tick off some of the easy questions that are here for you all while we're waiting on Matt. We have a couple of questions floating around here about union employees utilizing vision and dental through the GIC. Just a note that if you're a union member, your vision and dental is through your union, and so that's not within the GIC's kind of purview. So please check in with your union regarding your dental and vision benefits. Matt, I think we were left at the benchmarking GIC benefits slide. If you wanted to pick up from there.
Yep. My apologies for that. If we can move to slide 22, I think, right? Okay, so this is the first change that's being considered by the Commission to meet the budget objective that we've been given. But first, let me orient you to this slide a little bit, since there's the same format is used in the subsequent slides. So below the blue bar here in the left-hand column, you will see the description of the proposed change, which I'll talk about. And then reading left to right, we include columns that display information about the impacts of the proposed change. First, we show, where applicable, a comparison of the change to coverage that's in place today in insurance plans that are also offered by public sector employers. The next column to the right shows the number of members impacted by the change. The next two columns show the savings produced by each change and to the state budget and also to our premium. And then finally, on the far right, under the purple columns, we'll have colored bubbles that show how each of these changes aligns or does not align with our strategic priorities of member affordability, behavioral health access, and health equity. So the proposal that's laid out on this first slide relates to the premium contribution percentage that applies to a specific set of our members. And this is, it applies when the spouse of a state employee that retains insurance coverage after the employee has passed away. So today, those members pay 10% of their premium, while the deceased spouse may have had a higher percentage, 10, 15, 20, or 25%. So here we would be making the change to have the surviving spouse's premium to match the premium contribution that applied for the subscriber. I'd like to note that this is for state employees only and applies to those enrolled in active plans and Medicare plans. As you can see, this change would impact a little over 8,000 members, would reduce our spend on the budget by about $3 million, and would obviously work counter to member affordability, since those members would be paying a higher portion of that premium. So that is the first proposed change. On the next slide, we lay out a few more. Most of those on this slide are relatively small in terms of the reduction in our premium, but are nonetheless necessary to meet our budget savings target. For example, the first row shows a proposed increase with just a very modest impact, increasing urgent care copay from $20 to $30 would bring us in line with our benchmark of $30 that exists in other public sector plans, would impact about 60,000 members and produce about $400,000 in budget savings. Similarly, I'll skip to the third row briefly. We were proposing an increase to co-payments for an emergency room visit from $100 to $150, would decrease our premium by about 1/10 of a point and impact 41,000 or so of our members. The second row that you'll see here grayed out, this is grayed out and struck because we've decided not to move forward with this change, though we had presented it prior to the commission. We have, since the start of COVID, offered 3 free telehealth mental health visits without any cost to the member. And we are maintaining that so that we can continue to expand access to behavioral health services. In row 4, the proposal here is to narrow the scope of coverage for hearing aids to only that which is required under a legislative requirement. So this will affect about 2,500 members and would reduce the upcoming premium increase by about 1/10 of a point. So you'll see here we are narrowing the coverage for those under the age of 22 and eliminating coverage for those 22 and above. On the next slide, the 2 rows here are the first 2 rows here are related. At our December commission meeting, we had discussed increasing coinsurance that applies in our broad network plans. These are plans with an out-of-network benefit. We had proposed increasing the coinsurance from 20% to 40% for out-of-network services, which again is in line with the benchmark comparator plans in the public sector. We've decided to modify this somewhat to have it apply only to medical and surgical services and not to behavioral health services. We acknowledge there's a shortage of behavioral health therapists. Many of them do not contract with health plans, and we were concerned that including behavioral health services in this change would lead to a substantial barrier to access to these services. So the proposal that we're now moving forward with that I described is in row 1. The last row here proposes a change to the way our health insurance plans pay providers who are out of network. This should not, if implemented the way we hope to, increase costs or provide any access problems for our members, but it is simply a change in the way that our health plans pay these providers. We would be reducing the amount that we pay those providers for out-of-network services with the incentive to them to come in network with the plans with which we work. So on the next slide, we have a few more changes here. So these relate to co-payments for office visits to primary care physicians and to specialists. As you are likely aware, we have tiered co-pays for these services today, and these we use to incentivize members to choose lower cost providers so that we can keep our overall costs down. So changes to co-pays are a little more complex. We have to make changes to each of the tiers. So we lay that out here on the left-hand side. So for primary care visit co-pays, today, those on tier 1 are $10. We're proposing to increase those to $15, which is still below our benchmark comparators. Similarly, tier 2 co-pays increased by $10 and tier 3 by $15. A similar logic applies to specialist office visit co-pays. Tier 1 would increase by $5, tier 2 up by $10, and tier 3 up by $15. And you can see the resulting proposed co-payments. Finally, on this slide, the bottom, sorry, bear with me for just a moment. Okay, so on the bottom, on this slide, the bottom two rows are related. Here we gray out the bottom row for a slightly different reason, because these two rows represent a choice. We could either do one or the other, and we've chosen to do to propose to move forward with the middle row here as it relates to deductibles. So the proposal we have put before the commission would increase deductibles in our broad network plans for individual coverage from 500 to 750, and for family plans from 1,000 to 1,500. For our limited network plans, which today are 400 for individuals and 800 for families, we would be increasing those to 650 for an individual plan and 1,300 for a family plan. And again, we gray out the other alternative, which did not produce sufficient savings to meet our budget target. So finally, on the last slide, we are proposing some changes to our pharmacy benefit. The first is the introduction of a new program called Prudent RX. This is a program offered through CVS, which is administers our pharmacy benefit. The program lowers copays for members to $0 and saves the GIC almost $14 million in spending. This is accomplished by applying coupons that are offered by drug manufacturers and doing so behind the scenes for a certain selection of our highest cost specialty drugs. So the coupons, so in order to gain the benefit of this and the zero copay, members must enroll in this program, or your copayment is at risk of increasing substantially. There is nothing that any of our members need to do proactively at this point. If you are on one of the drugs that is subject to this program, you can expect to hear directly from CVS about next steps that you will need to take. And the second one on this page, and the last plan design proposal that we present, is eliminating coverage for GLP-1 drugs for weight loss. As I mentioned earlier, we have engaged with Vita Health to save money on these drugs and to meet that budget savings target. But covering this drug remains extremely expensive. Dropping this coverage would save us $46 million in the next fiscal year. And I'll come back to this. I'll come back to this topic of GLP-1 drugs in just a moment. So in the next two slides, I'm just going to sort of summarize high level what we've just told you. Actually, that will be on, yes. Okay, so at the outset, I mentioned that if the GIC were to make no changes to plan design, we would be projecting an increase of about 10.9% in our premiums for the coming year. So that's the red box in the upper right. If the commission adopts all of the proposed plan design changes, our premiums on average will decrease by approximately 4.9%, which you see here in the yellow box. This would produce a lower premium increase of about 6%, which you see in the red box in the lower left. Premiums would still be increasing, but at a significantly lower amount. It's important to note here that these are all averages. We have not yet set premium rates for each of the individual plans. So some plan premiums will increase more, some plan premiums will increase by less. So as we always say, it's important to use the annual enrollment period as an opportunity to evaluate your options and make sure that your plan meets your needs. So now we'll start to bring some of this together. In the next slide, just as I noted earlier, we've worked very hard at the GIC to keep your co-payments and deductibles low and stable. In fact, aside from a very minor adjustment that we made in fiscal year 24, we have not increased member cost sharing in 8 years. This is very unusual. Employers in the private sector routinely increase member cost sharing to keep their premiums low. We've done everything to resist that, but with the state's budget challenges this year, that is becoming increasingly difficult. So we are proposing some modest cost sharing increases, as well as some premium contribution changes, as I said, for surviving spouses. We're making some needed reforms to out-of-network payments. We're implementing a pharmacy savings program, each of which should have minimal impact on our members' costs. Those two specific programs. And I will say GLP-1 drugs to treat obesity, that is a unique challenge. So I wanted to just say one more word about the GLP-1 drugs for weight loss. We can move to the next slide. So the extremely high price of these drugs is a very significant driver of our rising costs. Most health insurance companies and many employers, but not all employers, are actually dropping coverage for drugs for this drug. But they do present an enormous benefit to our members in terms of health and wellness, and particularly for those who use these drugs. So so we struggle with trying to maintain access to these drugs. We did, as I said, implement the Vita Health program to manage this cost. But if the GIC is going to reach the state budget target that we've been given, we will have to follow suit with other employers and end coverage in fiscal year 27. I say this, but I also say that our commission is really struggling with this decision. And if you go back and watch the video of our January commission meeting, you will see that they are struggling with this. And it's ultimately the commission's decision on whether we make that change. And they will vote on that, as it says here, on the 12th of February. So one last slide for me, and then I will stop talking and hand it over to my colleagues to close out the presentation. So just a quick overview of the process that we go through to prepare rates and plan design. We are in the middle of this process in the area highlighted yellow, but we actually started this process back in December, when we started talking with our commission about our budget challenges and spending trends through the year. The second step, as we did last week, is to present our proposed plan design changes to the commission. We then come to you this week to socialize all of these potential changes with you, our members, inform you of the work. And then finally, we will bring it to our commission for their vote on February the 12th, and then final vote on plans, plan-specific premiums on the 26th of February. Then we move on to annual enrollment and coverage effective on July 1st. So with that, I will conclude this portion of the presentation and hand it back to Erica for the final section.
Thank you, Matt. So you all are doing an amazing job with peppering us with questions in the Q&A function. we're doing our best to get to them. Just a reminder, if you have a personal question that is specific to your situation, please don't put it in the questions. Please reach out to us via our online contact form, which you can see here on the website. You can access that by going to our GIC website, which is www.mass.gov/GIC. You can get to all of our information there. So again, if you have personal questions, please reach us there, and we'll do our best to answer your questions in writing. Now, if we could just go to the next slide. Great, thank you. So now we'll turn it over to Paul Murphy, who is our Director of Operations, to go over enrolling in and updating your GIC benefits.
Thanks, Erica. If we can go to the next slide. The next few slides that we're going to be presenting just give you some housekeeping details. First one here being annual enrollment this year will take place from April 1st to May 1st. During this time, people can enroll in GIC benefits, change your health plan, change your coverage from individual to family, family to individual, enroll in retiree dental. So if you want to make a change, April 1st to May 1st is the time frame you need to make that change. If you do not want to change anything on your GIC benefits, you do not have to do anything. So if you do nothing, nothing will happen. At the bottom, you'll see about this year's benefit guides. The guides will be available immediately prior to the start of annual enrollment. The guides will be available on our website, as well as in the GIC member benefit portal. The guides will have all information regarding benefits for this year, upcoming annual enrollment, as well as all of the new rates. Go to the next slide. This slide here, we just like to remind everyone that a few years back, GIC rolled out a member benefit portal. Currently, to date, we have about 136,000 members using the GIC benefit portal. We encourage members to register if you haven't already done so for the GIC portal. The portal will give you real-time access to your benefits. You can update personal information. You can make changes during annual enrollment to your health coverage. You can enroll throughout the year with the qualifying event, and you can update dependent information. To find out more information on our portal, you can visit our website, mass.gov/GIC, and you'll see a tile on there about the My GIC Link benefit portal. And go to the next slide. This slide here, we're just presenting the health plan information, telephone number, website. At the top of the screen, you'll see if you have information or you need information on finding a provider, accessing tiered doctors and hospitalists. I see a lot of questions in the Q&A about how do I know what tier my doctor is in? Determining what programs about telehealth or fitness or understanding your coverage. These topics here, as well as tiering, you have to contact the health plan directly. You can visit the website posted here, or you can call the health plan directly. On the GIC mass.gov website, we also have telephone numbers and websites for all of our, not only health plans, but our life insurance, long-term disability coverage, etc., that you can contact the plan with any additional questions. In addition to the plans listed on our website, they are what we call hyperlinks. If you click on the hyperlink, it'll take you to a GIC specific page for that plan where you can find out information on benefits. And I think that's the last of that slide. Q&A.
Thank you, Paul. Great. So we're now moving into kind of the more formal Q&A portion, where I will do my best to sort through all of the questions here and get them answered for you all. So the first question that we have, and we get this quite a bit, is why the GIC doesn't offer a +1 plan as opposed to an individual and a family plan. Like I said, we get this question annually. So, Matt, if you could take that question, and I'll go off.
Yeah, so we this is going to sound, for those of you who have listened in prior years, this will sound familiar. We do continue to evaluate the potential of adding a +1 plan type. We are not moving forward with that this year. Our analysis indicates that it's look, what we try to do every year is to balance the needs of our entire membership without having sharp increases being focused in on one subgroup. And to this point, our analysis indicates that that it would have that effect within our membership. So we will continue to evaluate that for future years, but we're not making that change for FY27.
Thank you, Matt. Great. Let's see here. We've gotten a couple questions about plans that are available to folks who live outside of Massachusetts and also outside of New England. Cameron or Andrew, if one of you could take that question on just to help folks understand what options might be available to them if they're outside of New England or outside of Massachusetts.
Sure, I'm happy to talk to that if we like. Yeah, because we are a Massachusetts state-based organization, our focus tends to be on Massachusetts residents first and foremost. But recognizing that it's a small state and with lots of border residents, we've tried to make sure that we offer as comprehensive a choice of plans as possible when it comes to residents of our border states. Now, we have some unique protections in the way of the balanced billing protection that only apply within Massachusetts to GIC members. So that gives us more leverage within the state. When it comes to residents of other states or, even the, Martha's Vineyard or Nantucket or the Cape, where there are fewer providers, fewer GIC members, we do have less leverage. Those more isolated facilities on the Cape and Islands, those tend to be much more expensive as well. So that's why they tend to be excluded from our limited network plans. So, we've tried our best to strike a balance with options for residents of the immediate border states. But then when it comes to managing, our membership spread out throughout the country, we have such a small number of residents outside of New England when it comes to our active or employee population that it's hard to take those into consideration. So what we focused on is for the country broadly is most of our folks in those plans are non-Medicare retirees. They either don't have enough payments to Medicare to be eligible for the benefit, or they're retired and on our plans before the age of 65, and they're not able to participate in Medicare just yet. So we tried to design plans that have broad access as well as partner with, networks and provider groups that would, service our membership, particularly with the retirees who tend to concentrate in those Sunbelt states like Arizona, Florida, Texas, what have you. Were there any other questions regarding out-of-state coverage or things we wanted to address?
No, I think that covered it. Thank you very much, Cameron.
Okay.
let's see here. We'll move on to another question. As you all are asking questions, the questions are moving for me, so please just bear with me while I get us oriented here. Let's see. We've got a few questions around removing a coverage for hearing aids and why that is a potential change that we're looking at. I wanted to turn it to perhaps Andrew just to speak to kind of the mandate from the state and why we're looking at that as a potential change. Andrew, is that something you could speak to?
If I had gotten the beginning of the question, I'm sorry, I was typing.
Sorry. No, that's okay. So we have been getting a few questions specifically around the hearing aid potential plan design change. And I know folks are concerned about that, understandably, but just wanting to see if you could speak to what we are mandated to cover by the state and why it is that we're bringing this up as a potential change.
Essentially, the state passed a law a few years ago that affected all the public, affected the commercial, managed care plans, and also specifically put a provision in our statute that mandated a certain level of hearing aid coverage. We at the time elected to enrich the coverage to be better than what was statutorily required. There is a cost to doing that. And given the cost pressure on us, one of the places that we looked at where we could save some money would be to just provide the coverage that we are statutorily mandated to provide, which is what the coverage will be if the commission were to vote as it does, as has been proposed. Does that answer the question? Do you want the specific?
I think so, Andrew. Thank you. There are a lot of questions about kind of why that would be a proposal, and so just wanted to make sure that that we touched on that.
People on Medicare plans have different coverage.
Yes.
Because Medicare has its own hearing aid coverage. So just
Great. Thank you. This might be for you while I've got you, Andrew. We've also gotten a couple of questions on Prudent RX and the drugs that will be on the list if we have that information, and if folks will have to be proactive in getting enrolled. Could you speak to that?
Yeah, we don't know what the exact list is. The Prudent RX will be some subset of specialty medications, and there'll be medications that have manufacturer coupons associated with them. It's what's called a coupon maximization program, and if the commission votes for it, CVS will get a list from CVS of what drugs are covered at the time, and they'll be proactively outreaching to every member who has a prescription for one of those drugs to enroll them. The member has to enroll in the program. If a member doesn't enroll in the program, these drugs get removed from the normal formulary and they have a 30% coinsurance that gets applied. That will be covered by the Prudent RX program if a member is enrolled, and if caught, then the member will pay nothing for the drug. If a member doesn't enroll, they'll end up facing that 30% coinsurance. So there will be a whole rollout if this happens with a lot of proactive activity to reach members so they don't get caught in this. I just don't know what the drugs are yet.
Thank you, Andrew. Great. Let's see here. So we had a couple of questions about kind of what the average cost increase that we might be able to see. If we could go back to the initial slide, Leslie, that has the aggregate increase that we're looking at before any plan design changes have been considered. That would be really helpful, just so folks can have eyes on that. And while Leslie's bringing that up, the aggregate expected increase is about 10.9%, and that is before any of these potential plan design changes are voted on. So just wanted to make sure that folks were able to see that. Great. Paul, we've got a few questions around retirees and how they can go about enrolling with the GIC and also what they need to do for their Medicare pieces. Could you just give us a quick high-level overview? I know we have our Turning 65 video that will be dropping into the chat here. But Paul, if you could just give us a quick overview of what folks will need to do when they turn 65. And just a note, if you have specific questions about your situation, please use our contact form and we can help you out that way too. But a general overview, please, Paul.
Sure. To start, GIC recommends that if you are retiring from state or municipal service, that you send us a retirement application to continue your GIC benefits within 60 days of your retirement. So you can do the retirement qualifying event through the member portal, or you can submit a paper application advising us of your retirement. Couple of things to keep in mind. If you are under the age of 65, you, a spouse under the age of 65 at retirement, you can remain in your same plan that you have when you retire, or you can also change plans during any annual enrollment or at retirement. If you are age 65 or older at retirement, when GIC gets your retirement information, we will send you a letter in the mail to both you and spouse, if applicable, to elect a Medicare plan with the GIC. What this will require you to do is you and or your spouse must go to Social Security and apply for Medicare Part A and Part B. Under state law, you are required to take your Medicare benefits, and you can enroll in one of GIC's Medicare health plans that we offer to all state retirees and municipal retirees. So if you're over the age of 65 at retirement, we will contact you with a letter giving you your options for electing a Medicare plan with GIC, but you also need to go to Social Security and apply for Medicare Part A and Part B. If you're under age 65, you can remain in the same plan that you have until age 65. At age 65, if you are retired, GIC will send you a letter 3 months before your 65th birthday, advising you of your health plan options to elect a Medicare plan, as well as enroll in Medicare Part A and Part B. All of GIC's Medicare plans can be found in the GIC Benefit Decision Guide. They are also nationwide plans. So any hospital or doctor that accepts Medicare, all of the plans except one, Tufts Medicare Preferred Plan, that is a narrow network plan, and you do have to elect a PCP and you have to stay within the network. But all of the other plans, the Medicare plans that you find on our website or in the benefit guide, are nationwide plans. One thing to note, we get a lot of questions on, I'm not eligible for Medicare, what do I do? If you are not eligible for Medicare, GIC requires you to apply for your benefits with Social Security, Medicare Part A and Part B, and get a denial letter from Social Security stating that you are not eligible for Medicare. If that is the case, GIC allows you to continue in the same health plan that you had before age 65 or at retirement, but we do require the proof of Medicare that you're not eligible. Medicare will bill for their premiums. Part A is free, it's hospital insurance. Part B is around $202 a month. That premium is billed directly to the member or taken from a Social Security check. That premium is separate from the Medicare premiums that you see in the benefit guide. That is a supplemental insurance. So when you are retired and you get on a Medicare A and B, Medicare becomes your primary payer. And anything that is not paid by Medicare, your GIC supplemental insurance pays the balance. I think that's high level regarding Medicare, applying for GIC benefits. GIC, I just want to, maybe if this helps, give some information on the dental plan. We get a lot of questions about the dental plan, and there's many different dental plans that are out there. So if you are a union member covered by collective bargaining, most likely you have your benefits, dental and vision, through your union. GIC also offers a dental and vision plan to active employees. That plan is a small plan available to only managers, confidential employees, members of the legislature, or members not covered by collective bargaining. We get a lot of people asking us, can they join our dental vision plan? You have to be not covered by collective bargaining. Otherwise, you've got to go to the union plan to get your dental and vision plan. When you retire, the coverage ends under those active dental vision plans. And you have to do a little bit of homework. If you want to continue your dental vision plan with GIC, if you're enrolled in it, you have the option of continuing that through the COBRA provision. You can keep that benefit for 18 months following when you leave state service and retire. Same option is available to union employees. The dental vision through your union, you also have the option of continuing that benefit through COBRA. Some of the benefits of continuing under COBRA is that you get to keep the exact same benefits you had while you were working, whether it's the union or GIC plan. You have to pay 100% of the premium, but the benefits are the same. At the same time, you also have another choice. GIC offers a retiree dental plan to all of the state and some municipal retirees. That plan is administered through Altus, and that is a retiree dental plan available, and you can apply for that benefit within 60 days of your retirement. So you've got a little bit of homework to do, whether you want to continue through a COBRA option or you want to continue through or elect the GIC retiree dental plan. If you stay on the COBRA plan for 18 months, at the end of 18 months, you can then join the GIC retiree plan, or you can join the retiree plan during any annual enrollment period. One word to note, if you do join the GIC retiree dental plan and you choose to cancel that plan, it is a lifetime lockout. You can never get that plan back. So we caution everyone to know that if you're going to join the plan and you want to cancel that plan at a later date, you cannot rejoin the dental plan. So I think that was fast, high level, and
That was great, Paul, as usual. Thank you very much. Let's see. Here's a question for you, Paul. If someone retires in April, are they going to be choosing one of the current kind of plans and providers within that plan, or would they be enrolling for the July 1st date? So if they're retiring in April, when do their benefits kick in, and what kind of plan would they be selecting?
if you are retiring in April and you are currently covered by a GIC health plan, that coverage will continue after retirement as long as you send a retirement application to GIC. If you are not covered by GIC and you retire in April, you can enroll in GIC benefits at that time. You must be eligible to collect a monthly pension check, and you can enroll in benefits at retirement for the first time. If you're already in the benefits, those benefits continue upon retirement. If you never elected benefits when you retire, a year goes by, 2 years go by, you can join GIC during any annual enrollment as a retiree as long as you are collecting a monthly pension check.
Thanks, Paul. Okay, let's see. Bear with me just a moment here. So we're getting a couple of questions about kind of services like chiropractors and acupuncture. And wanting to know kind of how those will be implemented. So if we could just have a member of our staff, perhaps Cameron, if he's available, to talk about how rates for, or how copays for chiropractors and acupuncturists, and also behavioral health clinicians would be impacted with an increased copay.
Yeah, generally speaking, most of those mirror PCP copays on most of our plan designs. So they would also go up a commensurate amount.
Thanks, Cameron. So I think that covers quite a few questions in our outreach here, or in our Q&A here. So we've gotten a couple of questions about, how you as members can provide your feedback to commissioners specifically. And I've mentioned this before, but please go ahead, and if you have specific feedback for commissioners, you can email us at gic.info@mass.gov. I will be on the receiving end of those emails, and I will be personally compiling member feedback to provide to our commissioners. So for those of you, and there are several of you who have asked in the Q&A, how you can get your feedback to our commissioners, please go ahead and email it to gic.info@mass.gov, and I will make sure that they have access to that as well. Okay. So we have a question here about why doesn't the GIC offer a high deductible plan? And so, Matt, if you could take a stab at that one or pass it along.
Yeah, it's a good question. And I would say those types of plans with a high deductible that are paired with a health savings account are growing in popularity in the private sector. They do bring with them generally lower premiums, but of course, by definition, a much higher deductible. We have evaluated a great deal of research that gives us pause about those types of plans because they tend to lead enrollees to defer necessary, important preventative care and not kind of discretionary elective care. So I think, they may present for some the opportunity for that lower premium, but our concern is over time they will lead to higher disease burden and ultimately higher costs.
Thank you, Matt. Gotten a couple of questions about the questions and answers that are available, that are kind of going on here in our Q&A function. Will the transcription be made available? The transcription itself will not be made available. There are folks who have input their personal information into some of the questions here, so we're not going to make the transcript itself available to folks for that reason. But as I mentioned before, we will be utilizing the questions you all have asked and going through them along with the ones from earlier, the session earlier today and the session that's happening on Thursday morning. We'll be going through all of those and we'll be sure to kind of compare them to the existing FAQ documents, updating the FAQs where we need to, and adding some where we need to. So if you're looking for FAQs, please visit our FAQ website, which has been put into the chat, and we will have those updated as soon as we can. Again, the videos and the presentation will also be made available. Okay. We got a question here about, sorry, it's moving on me. Hang on. Got a question about how retirees' plans are impacted here. So Matt, if you could just speak to kind of how these proposed or potential plan design changes impact commercial plans or non-Medicare plans as opposed to Medicare plans, please. Thank you.
Yep. So the full list of changes that we've proposed here will apply to our active employee plans. And I think, as I noted during the presentation, there are two that specifically also impact Medicare plans. So the elimination of coverage for hearing aids for those of the age of 22, and the change to the premium contribution for surviving spouses will also impact those in Medicare plans.
Great, thank you, Matt. Let's see. We got a question about how many members live outside of Massachusetts. I'm not sure if we have that off the top of our heads, but if someone on staff does, please feel free to jump in and answer that. Let's see. So we have a question here back to Vida. If the Vida provider decides not to prescribe a GLP-1 or to discontinue a GLP-1 prescription access, is there an appeal process in place? What avenues does a patient have if they disagree with the decision? That is not an answer I have off the top of my head. I would like to turn over to Andrew or Cameron. And if it's not an answer that we have on hand right now, it is a question that we will bring directly to Vida at our weekly meetings with them. So Andrew or Cameron, do you have
I'm
an
sorry,
answer?
what was the question?
If Vida denies access for someone who is on a GLP-1, is there an appeals process in place? And if we don't have that question or that answer off the top of our heads,
We do not have that answer off the top of our heads,
Okay.
and we will be providing something
Great.
in
Yeah,
the
so
FAQs to answer that.
great, thank you. So we do, we meet with Vida weekly, and your questions about these where we don't have the answers off the top of our heads, we do bring these questions to Vida directly and get them answered. So, and then update our FAQ documents based on that. Great, so wow, we've answered 256 questions. We still have about 30 remaining, maybe a little less than that. Again, we will be getting to these questions via our FAQ page. So please bear with us if you weren't able to get your question answered. Again, if you have a specific question for you, please reach out to us via the contact form on our website. Leslie, if you could bring up just the kind of question and answer page just to help us out a little bit with the directives there onto where folks can get in touch with us. So again, if you have feedback for commissioners, you can give us, shoot us an email at gic.info@mass.gov, and you can view our FAQs on the GIC's website. Again, if you have a personal question, you can reach out to us on our contact form. But for now, thank you so much for joining us. We really appreciate all of your feedback, and please stay tuned to the vote on February 12th, where the outcome of all of these potential plan design changes will be revealed. So thank you very much for joining us today.